This conference will now be recorded.
Hello, everyone. Welcome, and thank you for joining us for today's Tech Talk conducted by the ACRM Technology Networking Group. If you're not a member of the technology group yet and would like to join, please visit the website that has been provided on the slide, or contact one of the co-chairs, Tracy Wallace or Rachel Proffitt. My name is Shatanaka Bhattacharya, and I'm the co-chair in the Communications Task Force within the ACRM's Technology Networking Group. And our speaker today is Dr. Rachel Proffitt, who will be speaking on harnessing technology for precision rehabilitation. Now, before we move forward with this exciting topic, I want to go over the online meeting tips. Please know that this meeting is being recorded and we will make this recording available to you. I'd like to ask all attendees to keep their phones or mics muted and keep your cameras turned off throughout the presentation. We do expect to have about 20 minutes available for discussion at the end of the webinar. So if you have any questions, please type them in the chat feature, and we will address as many of those as we can during the latter part of the hour. And with that, it is my pleasure to introduce Dr. Rachel Proffitt. Dr. Proffitt is an assistant professor with 10 years of research experience in virtual reality and technology for stroke motor rehabilitation, including quantitative and qualitative data collection methods, data analysis, and translation from clinical to engineering and programming. Dr. Proffitt has teaching experience in research methods and assistive technology and clinical experience in an inpatient setting, focusing on neurological populations and assistive technology evaluations. Dr. Proffitt, we really look forward to your talk and will now turn the presentation over to you.
All right. Thank you all for being here. I'm very excited to present for our first tech talk. Like Satanika said, the title is Harnessing Technology for Precision Rehabilitation. I have no commercial interest in any of the products that are being discussed today. I do have an R21 from the NIH, from the Eunice Kennedy Shriver Division of Human Development and Childhood, NICHD, that is funding the research for one of the projects that's discussed in this presentation. Learning objectives for today are to define precision medicine as it relates to behavioral assessment and intervention. And I left that really broad because I feel like that encompasses most of what we do in rehabilitation. Also want to talk about being able to describe how technology can be used in a variety of settings to capture precise and relevant outcomes for rehabilitation. We'll talk about, why it really is what those relevant outcomes are. And I hope that you can come away, maybe something from this presentation, or maybe something that you do a little deeper dive in after this presentation, to be able to identify two approaches or technologies that can be used in your practice setting or research or wherever you find yourself coming from. So let's dive into this. This is just a quick little screen grab. I simply Googled technology or rehabilitation technology, and you can see from here that the progress that we've made in honestly the last 2 decades and within the last 5 years has been incredible in the amount of technology that's out there now to support clinical practice in rehabilitation. The research, the funding for research has grown exponentially. And so it's really exciting to see what's out there. We saw things in, I can play it again, everything from, things that involve the upper extremity things impacting gait, there's robots, there's supported treadmills, there are you see several virtual reality headsets. And so just the variety is absolutely endless. And the question is, well, there's so much out there. What can we really do with it? How can we make the best of what we have available and the best of the research, being able to use it in clinical practice to have the biggest impact that we can for the clients that we serve? And then obviously COVID-19 has accelerated a lot of this forward. Fortunately, we saw some amazing changes to reimbursement and payment for rehabilitation services, particularly covering the telehealth realm. And so a lot of technology got captured in that. And so you can see, I mean, here's one, this is actually from colleagues of mine here at University of Missouri. We see several articles that have been published. This is one in physical therapy. You now find, if you look at American Physical Therapy Association, they have all kinds of resources available. This is just a screenshot from their page. So you can see resources for telehealth and practice. Similarly, from the American Occupational Therapy Association, they have all kinds of resources available to support OTs and telehealth, particularly in the age of COVID. And there's just been a real push forward for everything. And here's another example. This is a planning grant collective that I led in October. We'd actually planned this topic prior to COVID, and then we were able to be flexible in the way in which we were bringing people together. But there really is this push to being able to use technology, and COVID accelerated a lot of that. So again, let's talk a little bit about what I'm calling precision rehabilitation, and then loop back around to this discussion on technology. So most of you have probably heard of precision medicine, and that's probably a more popular term. We're seeing all kinds of precision medicine institutes pop up. We have one here at the University of Missouri called NextGen. And I think a lot of people think about that, and they think about genetics. They think about pills or treatment approaches that are very medically based, that are take someone's specific genetic profile, underlying characteristics, family history, and make something that is really targeted to what they need. And that's one small facet of this. Here's a definition from the Precision Medicine Initiative. It's an emerging approach for disease treatment and prevention, which I really like that they included that, that takes into account individual variability in genes, environment, and lifestyle for each person. There is a push by the National Institutes of Health. They have what's called the All of Us research program, and their goal is to build out large databases, support large-scale research, and making decisions and helping advance treatments based on, not just people that were, that volunteer for research programs. That's a very small slice of society, but being able to truly represent, everybody that we want to see involved in research, and so that we can generalize our findings to the broader population. So then precision rehabilitation. So there really is no definition for this. I've seen a few that have been tossed out there in several publications, but there's nothing really truly defining this. So I'll pull from our Precision Medicine Initiative definition and highlight the components of this that I think are really applicable to what we do in rehabilitation. So an emerging approach to account for disease treatment and prevention, and that individual variability. I'm an occupational therapist by clinical training, and one of the things that is really hit home while we are in school and in our everyday approaches as OTs is that client-centered care. And I think that holds true across OT, PT, speech therapists, wherever you're coming from, is that we make it truly client-centered and focused around the needs of the individual. I currently teach evidence-based practice for my students, and one of the first things we talk about is basically evidence-based medicine or evidence-based approach. So it takes into account the clinician's knowledge, what the evidence is, and honestly, I think one of the most important factors is what the client wants and needs. And so precision medicine is really getting, and I think they've started to come around to realize that, oh, we really do need to take into account individual variability, and there's not a one size fits all for our treatment approaches. And then the other piece that I like that they include in here is the lifestyle. And a lot of what we do in rehabilitation, it's not just, let's do this one, give somebody, we don't, give somebody one pill and move on. Most of our approaches are very behavioral in nature. They require an intensive interaction between a rehabilitation provider and the client that we're hoping to either work through their condition, their diagnosis, or hopefully help prevent further exacerbations. So let's get, you may be going, okay, that's great and all, but how do we do that? So I wanted to give some real world examples, and hopefully, I don't have all the answers to this, but hopefully get the ball rolling, get the conversation started, get more people start thinking about this in the ways in which they conduct their clinical practice. If you're a researcher, maybe your choice of outcome measures, the way in which you design your interventions, the way in which we design clinical trials. So hopefully this can be really informative across the board here in rehabilitation. So one of the things that most people jump to immediately when we think about doing this is our ways of monitoring and measuring our outcomes for clients receiving rehabilitation services. I pulled a few examples from some colleagues of mine. This is the figure here on the left is from the Shirley Ryan Ability Lab, and they're proposing to use smartphones, which would, and most of us, I'm pretty sure all of you are sitting with a smartphone of yours, either right next to you, or hopefully you're not texting in my presentation, but you have it with you, right? And it's with you most of the time. So they're proposing to have this go with individuals who have a stroke. There is an app that collects movement data using GPS. The wonderful thing about our phone technologies is that we have accelerometers and gyroscopes, and now we even have more advanced tools that are built into our phones to be able to capture all that data without the client having to log in and punch stuff into an app. It's already being collected. It's sort of some of those what we call ambient monitoring and measurement, and be able to look at do we see different levels of activity and get a sense of and it's a little bit different right now with COVID, but are people getting out into the community? Are they leaving their homes? Are they leaving their neighborhood? Are they leaving their town? What sort of interactions do they have? And do we see then improvements in levels of activity, and then levels of participation in everyday life and society? Because that's where most people want to see the change that are receiving rehab. Here's another example on the right side of the screen from Catherine Lang's lab at Washington University in St. Louis. They use simple accelerometers, so similar to the smartwatches like the one I have here. These are designed for, the ones they use are designed for research, and they're able to, they can put one on each wrist of an individual who's had a stroke, and we can get a sense of, and these graphs are wonderful at showing symmetry of movement. We can look at intensity of movement, and we can see then changes as people, recover after a stroke. And we can look at and measure before and after or during interventions. And it's a nice way, again, a little more effort required on the part of the participant, but people are able to put something on, and all they really have to do is just wear it. They might have to charge it, remember to put it back on after they take a shower, but it's still, there's no buttons really for them to push, they just stick it on and go. And we get a lot of data from that. Other areas when we think about, we saw lots of the examples under the rehab technology. A lot of those were robots or virtual reality-based games, treadmills that somebody was walking on. And the thing with those is, those are wonderful. And this was an area of research of mine for a number of years. The thing about this is that people, they have to open up whatever this thing is and play it or interact with it. And it's only collecting data while they are in front of that technology or that screen. Again, this gives us a huge amount of data, but it's sort of that one step back from a wearable. Now it's then requires some sort of interaction on their part. So it can tell us how they're doing while they're interacting with it, but it's not giving us that data all the time. So there's some benefits to it, and also some limitations. So how do we do this in a way in which it doesn't require that participant interaction, and it's something that doesn't require, it can capture it more or less all the time. And so this is one of the things that we've been working on here in my lab, we started out with the Microsoft Kinect because it was a wonderful depth sensor. And like I said, I was using this for virtual reality video game approaches. And could we get a sense of, tracking the person in their everyday environment? And initially we said, okay, well, the home, right? I wasn't about to go into, where in the home would we put this? We've got, the bedroom, and bathroom, that's a little weird. I don't want to go there. And we thought about the living room. We could capture people walking around. But then I thought about what most people do in their living rooms, and that's sit and watch TV, or sit and have a conversation, or sit and read. They're sitting. There's not a lot of activity going on. And so then the last room in the house was the kitchen. And most people, there's a lot of activity that occurs in the kitchen. Even if they're not cooking, they may be helping a child do homework. They're warming up their coffee, they're maybe walking around having a conversation. A lot of times the kitchen for people can be the place that they pass through to go to other rooms in the house. They might go through and do some sweeping. Who knows? And there's just a lot that can go on. Sometimes I know a lot of you, right? You just run in real quick to grab something and then walk back out. But you're at least doing some sort of movement, activity, interaction in that space. And so we said, okay, what can we capture? And being the OT that I am, I had this whole list of different things that we could do. I sat back and I did sort of a breakdown of all the different activities. And we came, cutting and stirring and chopping and walking. So we looked at like 28 different actions that I tried to see if we could capture and distinguish from one another. This is in the kitchen that we have down in our clinic. So we put the sensor in there. And I'm not going to walk through all this. Again, I'm an OT, not an engineer, so I have wonderful colleagues that work on this. But I do want to point out is that basically what they're able to do is they gather the depth images. So these are the sort of dark gray pictures here in the screen. If you notice, it's not a color image, it's not a video image, it is a depth image. So you can't really distinguish individual participant features. It's sort of a silhouette outline, what we call it. And then within those, it's able to figure out when this walking occurred between the other things that were happening here. And basically, it's pretty confident that it's occurring here in this little space. You also see here, if you notice in this last frame, the little gray frame here, the person is starting to reach down for a cabinet below, and you see reaching below the waist is the next activity. It's starting to pick up and track right here in the bottom. So it's doing a good job. And then we sort of settled then from those like 28 actions that I started with into categorizing them to 7 different action categories. So we have walking, sitting, because some people just sit in their kitchen. Their kitchen may include a breakfast or dining room table. Sweeping, because a lot of times, there's sweeping or mopping that goes on. Kitchen involves water, things can get messy and wet. We also then one of the next categories was reaching above. And if you think about your kitchen, a lot of times we have things that are above a forward reach level, so those upper cabinets, or maybe you're reaching for a higher shelf in the fridge. There is reaching down below, so if you were to open your dishwasher or pull something out from a lower cabinet. Reaching forward, so that would be reaching forward to pick a pot up off of your stove, turn on the sink while you're washing dishes. I know I try my best, especially with the 5-year-old, to keep my counter as clean as I can. And so that reaching forward may include wiping down the counter. And then the last category, and this is where it's going to be interesting in how we categorize between what we call hand manipulation and that reaching forward, and knowing that a lot of these sort of can co-occur and occur one after the other as we move through our daily task in the kitchen. Hand manipulation would be things like if you are standing at the counter and chopping or cutting or stirring, things that occur within this frontal space of the body. And so what we did is we had people go through and do sort of simulated activities. So I gave them a script and I said, walk in the kitchen, you want to make some pasta. there's a pot in a cabinet under the stove, get the pot out, get the pasta out of the overhead cabinet, fill the pot up with water from the sink, bring it to the stove, stir the pasta in. Oops, you forgot something, walk out of the kitchen. So I just had them do a really quick scenario, and we knew what the different things were. And it did a pretty good job of detecting between those different things and distinguishing between those different activities. And so within the kitchen, within the simulated kitchen, per frame accuracy was about 85%, and per action accuracy was actually pretty good, about 92%. Generally looking at over about 80% accuracy is pretty darn good when you're looking at algorithms. We then, in addition to having people perform those actions in the training scenarios, we then have them perform different things in a random sequence. So we didn't know what was coming next. And then we moved from our wonderful little kitchen where everything is in the exact same place down in our clinic here in people's homes, right? Most people's kitchens don't look like what we have down in the clinic. Everybody has a different setup. Some people have islands. Some people have a sort of narrow galley kitchen. Some people might have a more open concept kitchen, right? Open concept's really big, or maybe not so much anymore. You know, people's kitchens look different. Some people have tables. Some people don't have tables. Some people, like I said, have an island with bar stools. You never know. Some people have a dishwasher. Some people don't. And we then moved it in the home and had people you know, do some sort of meal preparation. One made salad, people made sandwiches. So we have people doing different things, interacting, you know, some people were cutting or stirring or chopping. And as you can see, when we moved into the cooking, that's the data all the way on the right on this graph here, our per frame and per action accuracy went down, as we would expect. You know, it's a novel environment. It's the real world. Typically, when you move things, and this it goes for just about anything from the lab to the real world, there's a lot of variability there, and it's you know it's different. We have to adjust for that. So how are we adjusting? What we're doing is this is the R21 that we have. We're putting this in the homes of individuals who have had a stroke. And so you may ask me, well, what's the point of all of this, right? You're telling me about this really awesome depth sensor. We're able to detect activities. What does this mean? So as an OT, you know, for somebody who's had a stroke in the subacute and even in the chronic, you know, stage, in practice, we may see them once a week, once every 2 weeks. And I only really get a snapshot of how they're doing every time that I see them. I can get a sense and have them do some sort of contrived activities in the clinic or the lab, but it's not their own home environment. It's not their pot. It's not their coffee maker. It's not their spoon that they use. It's not their cabinets. It's not their stuff. And as an OT, I want to know, what are people doing? Not just so much how much movement are they doing, and you know, what's the symmetry like? That's really great. That's wonderful data. But as an OT, I want to know what they're doing. And I'll share an example from a colleague of mine. Her dad had a stroke, and she was chatting with him on the phone after a couple of months, and he was back home. And she said, "Oh, well, Dad, what'd you do today?" And he said, I got up and your mom hadn't gotten up, so I went downstairs to the kitchen and I made coffee for the two of us." And she stopped and she said, "Dad, you haven't made coffee since your stroke." And he thought, well, I didn't think about that. You're right, I hadn't. I felt like doing it, and it was kind of slow, but I did it. And you know, to her as an OT, she recognized that was something new that he hadn't been doing since his stroke. And so to be able to capture some of those changes is huge for us as therapists. And that gives us a sense of what people are doing in their everyday lives. And then can we then take that data and outside of just our traditional clinical assessment and what we see when they come in the clinic, we now have all this additional data of how they're performing in the home. So we could potentially pair that with our sensors, with the phone, with any other data that we can garner and get a more comprehensive picture of what's going on in that individual's life. And if we see changes that occur, if we see maybe a trend downwards, we can intervene early on. And we can adjust our treatment approaches and our treatment plans, figure out what motivates them, you know, figure out Maybe do we need to involve a caregiver in, in their everyday life, or do we need to move to more adaptive strategies versus remediation strategies? So there's a lot that we can do with this data. And right now, a lot of things we're working out some of those, technological issues, because it's technology. Every technology has issues. And then being able to then also pull out our skeletal joint data. So that's the little kind of rainbow colored figure here in the screen. Not only can we see what they're doing, can we get a look at how well they are moving while they are performing a reach overhead? How far are they able to reach? How quickly do they move? Do they overshoot, undershoot the target that they're going for? How smooth is their movement? And the depth sensor that we use is able to collect all that data, and we can do some calculations and pull those kinematic variables out. It's really exciting. And so here's a quick little video of, just a quick little opening the fridge here. And this is what we see from the sensor. And so now I'm going to talk a little bit about, integrating some of these technologies into, like I said, we could use that depth sensor with the phone, with a wearable. But what else exists out there to get at, some of those other data and give us a complete picture of what's going on in that individual's life? We think back to that definition of precision medicine. It's, being able to capture and measure all of those things to get that personalized approach to care. So one technology by itself may not be the most comprehensive, but if we use multiple things and see how they all relate to one another, we can get a more holistic or comprehensive picture of that individual, and then be able to make some personalized suggestion. So this is from the depth sensor that we've used is part of a sensor system that has been used in independent and assisted living for older adults, healthy as well as those who may have chronic conditions. These sensors themselves are able to send data into the cloud. We have algorithms that analyze to look at trends in the data. We can also pull in their health data that they give us, and then able to show that to the individual as well as any clinicians. So what does this look like? So this is from motion sensors, and I mean true, motion sensors that you might find. So when I lived out in Los Angeles, there are motion sensors in the bathroom that turn the lights on when you come in. Same thing here. Basically, is there motion detected? It then records an event. So this is data from actually almost 11 years now. They detected, motion August through September. They had some depression followed by a geriatric psychiatrist. And then after some personal losses later on, they had trouble eating and stopped going to the dining room. So you see this pattern from August, September, where they had lots of activity, to then not a whole lot going on between March and April. And they stopped going out of their apartment. Then, after some intervention, we then see this uptick in activity and the trends that go back to looking like it was before, they had lower energy and stopped eating. So this motion sensor, real simple technology, very cheap, easy to install, can get a sense of, where people are going within their homes, are they leaving their homes or not, and gives a sense of how they're doing. They also use bed sensors. So this is a look at the sensor that goes under the mattress. We can look at sleep stage detection and heartbeat detection. We can look at overall restlessness, and they are able to put 2 sensors under each side of the mattress. So if there's a couple, they can have one on each side and detect differences for each person. And then this has actually been used, especially with individuals who get up in the middle of the night, can help detect some of those early onset dementias and potential things like if they're getting up in the middle of the night, we have increased restlessness, and then we have increased bathroom activity, might be indicative of something like a urinary tract infection. And so again, like I said, there's a bed sensor there. I also then combine that data with the motion sensor to get a more comprehensive look at how that person is doing. And then the other piece of it is not only informing what we see as clinicians, and that's great and that's wonderful, but also putting some of that back on the individual. People are becoming more involved in their care and want to be more involved in their care. So we've developed a consumer interface that's shown on the Amazon Alexa device, the Amazon Echo Show actually, so that's the touchscreen one. And I'm sorry if I'm setting off any of your Alexas where you are. And they're able to show in a very simple way. So most people understand, red, yellow, green, right, from stoplights. Green's good, red's bad. Yellow, you're kind of questionable. And you can say, how am I sleeping? What's your sleep quality look like? And it plots from each day over the past, couple of weeks. What is my fall risk? And we use this, they're able to look at walking, and particularly in-home gait speed is highly predictive of fall risk. And they look at in-home gait speed from the depth sensor. It's able to track that and see if, here, this person looks like they're trending into the yellow and, within the fall risk category. So something to be cautious of. And that's where the individual can go, oh, there's something a little bit different here. Maybe I should reach out to my primary care physician, to the physical therapist that I'm seeing, and share this data with them. So I'm going to leave it there, and I hope you all can, I've shown you a couple of examples, things that are coming out of research labs where I'm working, a couple examples from other research labs, but really thinking about how can we use, like I showed all those technologies at the beginning, thinking about ways in which we can pull things in together and make care way more, like I said, it's precision rehabilitation, but it truly is, it's what we do as rehabilitation professionals. It's that client-centered care, what they value to improve what they want, what they value within their everyday lives. So is it being able to go back to work, being able to play with their grandkids, whatever it is, we can help move them towards those goals. And we can do it in a way that allows us to be more precise in our treatment approaches, be more precise in the assessments that we garner, and hopefully be able to save a little bit of money in the process. Insurance companies are always looking for that. But really it's being able to, and I love this here, we have the mission of ACRM, improving lives, right? That's our goal. So thank you all for listening, and we can turn it over for some questions.
Thank you so much, Dr. Proffitt, for the really interesting and informative presentation. I am hoping there'll be a lot of discussion on this, and please feel free to chime in with questions. Either you can type them in the chat box, or you can unmute yourself and ask your questions, or you can type the questions and I can read out the questions as they come in. While the questions are coming in, I'll go ahead and ask a couple of my questions that I was very interested in the kitchen related aspects. What were some challenges that you experienced when moving the system from the clinic kitchen to the home kitchen?
Yeah, I think the thing, so I'll talk about two challenges. One, when we went from the, where I told people a very specific order of what to do, and they typically tended to do each of those things one after the other. Then when we moved to just letting people do things in random order, and then also in their homes, and I think about how I cook. A lot of times, I grab this thing out of the fridge and I'm kind of carrying it, and I turn, and I might switch hands while I'm turning, place it down on the counter, turn around and pick something else up. And so I'm constantly moving and doing things with my upper extremities in the kitchen. I might take a step or two over to the sink to pick something else up. And so a lot of times the distinction between, if I were to ask, so we're sitting in a lab, I ask somebody to reach forward. That's one easy, simple reach, right? That doesn't happen in the real world environment. That forward reach happens while I'm also picking something else up and, maybe reaching. Things don't happen in a very clean way. So that's been one of the biggest challenges in being able to just really parse out when those things happen and train the algorithm, because it's very messy data, I should say, right? And we find that when we move into the real world, things get messy from a data perspective. And so being able to train the algorithm in that messy data environment to then be able to detect things in, in the longer, down the road and in the longer term. So that really has been the biggest challenge for us. It's coming along, and it's exciting to see where the potential of where it can go. But and just like I said, the real world is messy. But if we want to use things in the real world, we have to get messy.
Absolutely, but that's very helpful to know so we can prepare better for subsequent implementations. I'm sorry if I'm spelling some of these names incorrectly. Please, I really apologize. I have a comment here from Berna Stavrik, who says, "Thank you, Rachel, for your presentation. What are some of the challenges that you have had, and what recommendations would you make when working with engineers who have different skills, terminology, or points of view?" That's a really good question.
Yeah, and I mean, that's something that I've encountered throughout my career. So I've been working with computer scientists and engineers, and now more so with individuals in informatics, information sciences here at Mizzou. It's everybody does have their own language, right? So I'm an occupational therapist. We have all kinds of acronyms that we use. I think just a couple tips. One, being very clear in your communication and stopping yourself from using acronyms for one, and if you may have to define terminology. Sometimes there are terms that can mean two very different things to two very different professions, unfortunately, and it's the same word. And so I've had conversations with people, and we've come to, okay, how are we going to define whatever this concept is? I think the other thing is really being true to who you are and your background and your approach to things, and always having that in the back of your mind. But then also being open and embracing the opinions and, like you said, points of view of those who work in other fields. And a lot of times we can find that those points of views can be, it allows for and it fosters collaboration, and they can be very complementary. I find that working with engineers, most of them tend to be problem solvers. And as an OT, I'm a problem solver just about every day. And so it's kind of recognizing that we are both problem solvers. What is then helping everybody to define what that problem is, and then can we come up with new solutions to help address whatever that problem is. Sometimes we may have to be the people to help truly identify what that problem is. I have come across some people in engineering who maybe not that they make up a problem, but they don't fully investigate and understand what the problem is, or they assign a problem when there really isn't one and it's actually something else that's going on. So sometimes as a clinician, I tend to be the bridge between the engineering and then the solutions, and what the clients and their caregivers or family and friends, what they really need, or what, if I'm working with other OTs, PTs, speech therapists, the other clinician, what do they really need in clinical practice? So sometimes I feel like I'm that bridge or that translator between them. And I think the other one is sometimes you just have to more or less stand your ground and I hate to use the word, I don't want to use the phrase defend yourself, but just having real clarity for yourself. What's your background, where you come from, and what do you value? What do you find most important? What do your clients find most important? And always having that in the back of your mind when you have those conversations and when you're going through and designing interventions, working with the technology.
Great.
Yeah, look, I'll address the question. So yeah.
I have a question. Smalley. She says, you spoke briefly about the data collected by this technology to save costs during rehabilitation. How can we prove this concept to insurance companies to make them willing to pay for such a system? And on a similar note, I have a question from Susan Lin, who asks, are the sensors expensive or does it depend on the type?
Yeah, so I think that's sort of the next phase that we want to get to, is being able to do some of those cost effectiveness studies. And there's one study from the group, so this was prior to when I came to Mizzou, when they were investigating the use of that whole sensor system in independent living and assisted living facilities. And they were able to save, I believe it's on the, so one of the things that they're looking at is aging in place, especially for those older adults. Are they able to stay in the independent living apartment? It actually adds about 2.6 years that they're able to, longer that they're able to stay in their homes, so in the independent living homes. We're now moving into more of the community homes, so data will be coming on that. And the thing with that is then if you look at we know what the costs are per year for a nursing home, which is depending on where you are in the country, can be anywhere from, you know, $15,000 to I don't know what it would cost in Florida or California, but I'm going to guess probably in the $30,000 to $40,000 a year for nursing home costs, and a lot of that can be covered by Medicaid and Medicare. So think about it, if they implement this sensor system. So the sensor system they use in the studies here, about in sum total about 2,700, and that's with the ability to have a clinician looking at the data, versus $27,000. So 2,700 versus $27,000. That's enormous cost saving. One of the next goals that I have for this is to be able to you know, measure some of those outcomes and then show that this truly is cost effective. That being said, Susan, there are other options beyond just what we have here at Mizzou. So I'm working with additional colleagues of mine here to get a sense of, so there's an OpenHab system that's available. The motion sensors are fairly cheap. The depth sensor and the bed sensor are the more expensive things. So could we have, you know, maybe one of those sensors, and there are other lower cost depth sensors that are available to pull in to make it, rather than $2,700, it's somewhere in the, you know, $600 to $1,000 range, which would be a lot more affordable and even lower cost than for keeping people out of a costly nursing home or higher levels of care. Think about hospital admissions or a fall that happens for an older adult, the cost of care then just goes through the roof.
And the next question I have from Stacy is if you would like to talk a little bit more about patients facing Alexa, and are older adults seeing those graphs about their increasing fall risks or their behaviors? If yes, if you have found that this increases anxiety in those patients, or is it activating them to seek help?
It's kind of both. Right now, we're collecting a lot of this data, so we're doing quarterly interviews with people that have the Amazon Echo Show in their home. Honestly, for a lot of them, they don't look at their health data a whole lot. They like to ask Alexa, what's the weather, or what's the latest headlines in the news. They like the conversational style of Alexa, and that appeals to them. They don't have to push the button, they can just talk to it. They don't always access their health data. So I'll give an example of someone who didn't use it a whole lot. So this was in one of those 55 plus communities. So it was an apartment, but it wasn't one where they didn't have any nursing staff or anything on place. So it's truly like senior apartment. And one woman, when we went back and looked at the data from the depth sensor, we could see a decreasing trend in her in-home gait speed about 3 weeks to when she had a stroke. But fortunately, I don't know if it's fortunately or not, but she wound up falling when she experienced the stroke in her apartment. And so it triggered an alert to our research staff. And we looked at the depth sensor data, and basically we could pull up the live view of it, and she was laying on the floor. So we called the apartment manager, who, this was all pre-COVID, called the apartment manager. They went in, called 911, and they were able to get her to the hospital in time to get TPA administered. So she had pretty much no residual effects from her stroke. So great that the fall alert was put up. But the thing was, I think, if she wasn't looking at her data, and it's one that when I went back, my engineer pulled up the depth sensor graph for me, and I went right there. That's where we started seeing that downward trend. And pretty much any OT or PT that would have looked at that would go, there's something going on. To then maybe we would have had a telehealth call or a visit with her and said, hey, maybe you should talk with your physician. If she'd had some sort of healthcare visit, we might have then been able to take her blood pressure, and might have been elevated. We don't know, but she might have been able to get healthcare intervention before that happened. So yes, some of them are looking at it. Sometimes they still need assistance in being able to interpret and understand what's going on. So we're getting there. It's figuring out what that balance is. So this is older adult. That being said, so say, I'm only 35. Who knows, I might be one to, I look at the data that I get from my wearable sensor, and I'm a lot more savvy with incorporating that data into my day-to-day choices and behaviors. Older adults, maybe not so much. So it's figuring out how do we support those individuals that do have access to this, and being a little more, implementing some self-management strategies. And for those that might kind of go the other way and start looking at it, again, do we need to have some intervention so that they are not anxious and overwhelmed by the amount of data that they're getting, and sort of help them understand that we're looking at trends. We're not looking at just one day where maybe you just, you drank too much coffee later into the night, so you didn't sleep very well that night. That happens, right? I see that in data coming from here, but I remember what I did the day before, and I know that that's not a trend. That's just one day. It's when I look at the trends, that's where I see the differences. And so people need some support in being able to do that. Yeah.
I think those preclinical signs and trends are so incredible in terms of what we have the capacity to detect. And if we can start using sensors and trackers and the Internet of Things in that way to help people. But as you said, I think that it's true that the trends take time to show. You said it was about 3 days of declining.
Yeah, well, I looked back about 3 weeks from when her stroke happened, and then from there, I think it was, I started looking at probably after about a week's worth of data was when you really, we started seeing this sort of slope beyond just, any sort of deviation within, a couple of days, right? So typically for most of those, it needs at least, I would say probably at least 5 days worth of data to say that this is a trend that's occurring. Right. And the other thing that they have built into most of those sensors are algorithms to look at the data and say that there is some sort of trend that's going on now.
Right. And these trends might be different in length for different types of events too. And so that's like a whole nother area of research we could start. Just like that happened to be for stroke, but maybe it's for a future injurious fall, or maybe it's for a heart attack, or whatever it is. But yeah, really great work though.
Yeah, and then the other piece is, and this is the other thing I want to look at too, not only for cost, but then integrating it back into the electronic health record. Pulling data from the electronic health record to inform the sensor data, but then also the sensor data informs the electronic health record and the decisions we make as care providers, and then sort of having this loop. I don't think we can really call it precision rehabilitation until we make that complete loop.
Thank you.
Thank you. That was a really good discussion. Do we have any more questions? Great. I think we had a really good discussion. Thank you, Rachel, for sharing your expertise. It was really nice hearing about how to take technology to the homes of individuals. Do you see this being possible to implement even in remote, hard to reach areas where it might be more challenging to visit and set up the equipment? So maybe making it available to reach those individuals and having them set it up so you can mostly check the data remotely?
Yeah, so actually I just submitted an R01, or I resubmitted an R01. This one had a little bit of a COVID focus, but the focus on getting this into homes of older adults living in rural Missouri. So, you know, and we deal with all kinds of internet connectivity issues out there. And then part of it would be telehealth visits to help the older adults understand their data and make changes to their everyday activities and, you know, make different life choices, that kind of thing. But yes, I mean, living here in Missouri, we're surrounded. We serve pretty much a 2-mile radius, or 2-hour radius from Columbia. People come here for care. So it's really important to address those areas, and that's a lot of the United States is rural.
That's true. It's really important that we do acknowledge those remote, hard to reach areas and focus a little bit on that as well. I have a question here from Pam. Is anyone utilizing this with children that have disabilities upon discharge?
So pediatrics is not my area, but I can speak to one colleague. His name is Evan Dean. He is doing research with children in daycares and schools, and they put essentially, I don't know if it's phones or little wearables on them, and they look at language skills and other interactive, like social interactions with other children, and they're able to tell where those occur within the building itself. So in different rooms or sort of in different areas. So do they have more social interaction in the play area versus, you know, the eating tables versus the reading area in the classroom? And so I mean, I think that's really cool because you can get a sense of where do those happen naturally in the child's environment, and then we can, you know, start structuring interventions based on, you know, where we see some of those interactions occurring already. It's there, you know, we don't need to reinvent the wheel if things are already happening more so at this play structure, then hey, let's do it over here, because that's where we're going to see the child, you know, interacting and having those, you know, needing to work on those social skills or their motor skills or what have you. So that's the one big one that I know of. That being said, I know there's a lot of research in pediatrics. Stroke is my area of expertise, so I can speak a lot to that, but not so much in pediatrics. But I'd be happy to connect you with some of my colleagues that do work in this area.
Great, thank you. Not hearing any more questions, I would really like to thank Dr. Proffitt for being our speaker today and presenting this incredible amount of information on how to bring rehabilitation to our clients. I would really like to thank everyone for attending today's Tech Talk. Our next Tech Talk will be in May, so stay tuned for more information. The recording of this presentation will be available in the next 24 to 48 hours. Please do recommend the Tech Talk series to your colleagues, and I am looking forward to seeing everyone in our next presentation in May. So thank you, everyone. Thank you, Dr. Proffitt, again for this amazing presentation. We really appreciate the information that you provided.
Thank you. Pleasure to be here.